The best way that we can reduce the maternal mortality or maternal complications is we make family planning services be accessible to our population. Kenya national FP goal is to achieve an modern contraceptive prevalence rate of 58% by 2020. We didn't achieve that. 64% by 2030. We are almost there. Then 70% by 2050.
Migori County partners with the KMET in provision of family planning services that are quality to our facilities, and they also support us in training or supporting us in capacity building in a bid to give quality services and at least improve on our modern contraceptive prevalence rate.
Family planning helps us to improve the quality of life of our women. It gives room for individuals or couples to actually give quality care to their children.
The training is a 5-day training. We call it a hands-on skill. First of all, we have the class that we give actual lectures for the participants for 3 days, and then there is the onward practicum skills that we do for 2 good days. And then now, after the training of the 5 days, we also have the post skill, where we also need to know that participants actually gathered what they were supposed to gather.
It was a unique training because they were able to pull participants across the 7 counties that they support. That is Migori, Homa Bay, Kisii, Nyamira, Kisumu, Siaya, and Busia. So the participants were able to share a lot of experiences, what is happening in their area.
All modules were good, and all the facilitators were audible and clear. They were understanding, they are friendly. In fact, when we were going out for clinical areas, they accompanied us.
We had so many participants who scored zero when we did the pre-scales assessment. But I'm very happy that at the end of the 5-day training, when we do the assessment again, most of them actually are scoring above 80%, which means that they were very, very eager to learn, they were committed, and at least now they have gained the skills.
During the pre-skill assessment, we noted the gaps that the participants really had. And 2, they also accepted, or they would see actually what the gaps were. So even during when they were giving us, during the introductions, when we were beginning the training on Monday, one major expectation of most of the participants that whatever I'm not able to do well, that is what I really want to grasp.
I had forgotten some procedures. I was able to do, but the procedures, I didn't follow the procedures well.
I have never inserted an IUCD at my facility because it's a really sterile procedure, and it requires the equipments which we need to use for it to be successful.
Tulikuwa hatujui kuweka Mirena because hatukukuwa na updates ama information how it is inserted.
I've not been conversant to most of the methods because back in my place of work, we mostly use injectables and the implants. We rarely use the Cyana and the new methods.
This capacity building is also keeping to update yourself with the new innovations that are there, with the new commodities that are there, and we are now ready for the job market and ready for the community in whichever way they would come or approach us.
The coordination was so good for this training because we were able to have the theory sessions in class, and also very good arrangement to ensure that our team went to the field and practiced the skills. And when they came back, they were able to give feedback, which I think was also very useful for us in programming.
Tarudi like after 1 month, we see how it's going. 2 months, then utapata tu iko sawa.
The skills part is what makes me more excited, because especially something like IUCD insertion, I had, like bare minimal knowledge about it. But as for now, I'm confident because I've gained the required skills and now I can conduct a standard procedure.
Nimejua vile ya kuingiza jadeli vizuri, kupeana subcutaneous Depo-Provera, we are able to counsel the clients and offer services.
The problem is people are being fed wrong information in the village. The information they are getting from the village, they live by them, they transmit from one person to the other, minus confirming if it's true or false.
Hii ndio yenye ulichagua, tunaangalia kama iko expired ama iko sawa. So ukiangalia hapa, hii expiry ni lini? Mwezi wa 7. So means iko sawa.
Watu walikuwa wanasema eti ukiwekewa unahisi uchungu sana, na mimi hiyo uchungu sijasikia. Ukiwekewa labda ukishakaa tu hivi kidogo unaanza kubleed. Kuna zenye ukiwekewa uzai.
Watu walikuwa wananiambia kitu ni uchungu. Kuna ya miaka 5 ukienda kuweka utasikia, wanaweka 2 utasikia uchungu hadi utatamani kutoroka. Ndio nilikuwa natetemeka ile time. Sasa ukiweka kama hujazaa mtu mmoja utaiuzaa, utataka kuzaa mtoto utaipata.
I was able to do an insertion of IUD through the counseling. It enabled a client to change her mind from Jadel to IUD.
During my period of training, I was able to insert Jadel, which is usually for 5 years, and it has 2 rods.
I'm proud to say that yesterday I managed to insert 2 IUCDs and remove 1. So yeah, I'm very happy for that.
Some clients feel shy. They don't have to talk about that. You initiate at times. How may I help you? Are you on any family planning method, or would you like, to space your family, maybe after delivery, maybe postnatally, and things like that? The community or the clients really need to have good information about the methods that they really want. And in counseling really gives us, if you do good counseling, then probability is high that you may have also eye uptake for particular commodity. So we also had a session about counseling, quality counseling, so that we also have good or high acceptance for the method, including what side effects they may see about the method and how to manage them.
And family planning, we know, is a competence-based training.
We can't say that they are now perfect. We want to still work with them, agile. So when they leave the training today, then they go back to the facilities. They have the participant booklets or the trainee booklet of which they will continue practicing. They need to be followed up after 3 months before certification. And then we want to know how much skills are developed. Are you able to give all the methods that are available, improve on your method mix in that particular facility? Apart from that, there's ongoing support through phone calls. They can call, I have such a challenge. One may need to partner, or we can move in with the Huduma Poa team to just walk to facility and just give on-facility mentorship or on-site follow-up.
The participants have gained their skills, and now when they go back even to their facility, I'm sure they are also going to mentor others.
I've added knowledge and skills. So the procedures which I was not conversant with, now I can do it very well, and I can teach 2 to 3 people. I can mentor as many people as possible.
When we are completing the training, we usually draw action plans or work plans. One key about the action plans is giving feedback to the facility staff who are remaining behind.
I really want to say thank you to the partnership for enabling me, for enabling us, even the private hospitals. At least we have equal chances like the government and the public institutions.
One way of offering standardized services is that we have standard training across. There's no training for private and there's no training for public.
Yeah, we want to see that, yes, we have good services in public sector, but we also don't leave the private sector, because we have seen and we've learned from experience, including during COVID, that when there are issues in the public sector, the traffic goes where? So there's actually no private client and public client. We also want to see improved access, and that's why we are investing in whatever we are investing, so that we can ensure that in terms of SSRH and in terms of maternal child health, that communities are getting the services that they need to get.